So this presentation actually takes and sort of pulls together all of the pieces of information that you've been provided this morning. So our goal of medication is to, as Dr. Skinner would say, put the virus to sleep. You know, the medication acts to stop the HIV virus that's in the bloodstream from multiplying. And the goal at the end of the day, if we're able to help a client to become adherent, and we'll talk about adherence in a moment, will be a non-detectable viral load. So we cannot cure HIV, but we can get the virus so low in the bloodstream that our blood test can't really pick it up. It's really low. There's still virus there that probably can be transmitted if there is risks being taken. But this is our goal, to get that non-detectable viral load. And so in women have different challenges than men. So we're going to talk a little bit about those differing challenges and pull together a lot of the information that you've seen this morning. So first we'll talk about what does that word adherence mean. And we used to use a different term back when, compliance, but it made it sound like, you know, they had to be compliant. So there's a different tone to that. So we use the term adherence, and in the broad definition, and if you look at Katie's website, you will see they say taking medication exactly the way it is prescribed by your doctor, and taking the right amount of medication at the right time in the right way, and being consistent and not missing any doses. And if I polled the audience sitting here with me, I bet you not many could say that they have 100% adherence, which means that they take the pills that they've been given from their family physician or their specialist exactly the way that they're told to. You know, they probably busy in a month, they've missed 1 or 2 doses or maybe even more, or they stopped taking their antibiotics before they were complete. That's all what we talk about when we're talking about adherence. Why is adherence so important? So when we miss doses, it may affect the amount of medication that's in the body. So this inhibits the body's the ability of the medication to do its work properly, whether it's the medication, the HIV medication, antiretroviral, or whether it's your antibiotic. So in the case of HIV, it leads to an increased amount of virus in the body. And thus, when we've got an increasing amount of virus in our body, we're increasing that transmission risk, especially if there's risky behavior taking place. So missed doses can cause HIV to reduce more actively, and when it's actively reproducing, when there's some drug but not enough drug, then the virus gets kind of smart, and it changes a little bit, and it mutates. That's the sort of technical term, causing some HIV medications perhaps not to work or to become ineffective. And if you ever looked at the number of HIV medications we have, yes, it looks like we've got a lot, but once our virus starts to get a little smart and mutate, that cuts down the physician's options for each client. And so we don't want to ever get to that situation. Next slide. So over half of the global population of persons infected with HIV consists of women and girls. Women face a wide variety of barriers that are gender specific to this population. Social, cultural, economic, and environmental factors all influence their access to treatment and their adherence to medication regimes. So we've talked lots about those challenges, and those challenges specific to our women living with HIV in Saskatchewan, and these even more importantly in our population of women who are pregnant and living with HIV. And so the Athena group that works with United Nations Women stated, to achieve current global goals, it is critical to understand and to address these key barriers to and facilitators of women's access to HIV treatment. So here are some of the barriers that they identified in a study that they did. So fear of stigma and discrimination, and we can't talk about this too often. It still exists. You know, we think back to what happened in the early 80s when people were categorized, okay, if you're HIV positive, you must be a gay male, and we would think that this many years later, we've come a long ways, but in many ways we have not. We're still back in the days when someone, I recently had a healthcare professional say to me, what are you doing? And I said, I work with persons living with HIV. They took a step back. There was a piece of stigma and discrimination right there in their simple move of taking a step back from me. I can't transmit the virus to them, and the client can't transmit the virus to me, but that was their lack of education. So in this situation, where women anticipate the fact that there's going to be stigma and discrimination because they've been faced with this before, it may lead to their non-disclosure of their HIV status, which interferes with their ability to be adherent to their medication and their ability to access ongoing care. Women often come from marginalized groups, and this would include sex trade workers, transgender women, women who inject drugs. They're also all at increased risk for contracting HIV. They face high levels of stigma and discrimination in healthcare settings just for their being part of that population alone, not even being HIV positive. You can do it. They know too. Side effects of the medication also can be a barrier for women to taking treatment, especially in women who live in a population where they know others that are HIV positive, and they will come to you and they will say, oh, I don't want to start medication because I saw my friend and this happened to her. We have to remember when we're talking about HIV, everybody is different. Everybody's makeup is different, how they got their HIV is different, what their living situation is different. And so how our medication is going to affect them may be different. And so it's all about good counseling and educating our clients, because if they anticipate that they're going to have a variety of unpleasant side effects, they're not even going to want to start, and it may break that chain. They may have been linked to care and gone to see the specialist, but once they start talking about medication, they may not be ready. And so we've broken our chain, we've lost our link to care. If they anticipate that maybe there's going to be changes in their body habitus, and we all as women know, we're often looking in that mirror going, taking a look at ourselves, weight gain, changes in mental health. I had a client, and this was actually a male client, who had some issues when he started taking antiretrovirals. His immune system started to get healthy again, and he got something called molluscum on his face, and he could not cope with that. He stopped taking his medication, although he kept telling us he was taking it. And we even did therapeutic drug monitoring, and we tried to get him to take his medication, and he gradually failed. And unfortunately, he died of HIV-related issues. And when his mom went in to clean his room, there were stacks and stacks and stacks of medication. He had faithfully gone to his pharmacy, he had faithfully picked them up every month, but he never could get over that hump to take that medication. And sometimes we'll see women in that situation as well, and it's all about good counseling on part of nurse and on the part of the team to make sure that we have a client that's well informed and able to be successful at taking their medication. Sometimes they may have some GI concerns too, so nausea, vomiting, and diarrhea, and I've often had clients tell me, especially with some of the older medications that cause lots of diarrhea, and it was not the same kind of diarrhea you might have when you're sick. They actually suddenly would have to go to the bathroom. One patient said to me, I know exactly where every bathroom in Regina is, because he said, I'm not going to stay at home all the time, but I can't risk being out in public and have an accident. Medication regime, so that's the way in which your medication is the group of medications and how the medications are prescribed to you. They may interfere with your daily schedule. So we try our best to offer clients that one pill once a day. So you can get them into the situation where, okay, I get up and I take my medications, or I get up and I eat breakfast and I take my medications. Because some medications do need to be taken with food, some without. So, again, that's an education piece, so the patient understands the most optimal time to take their medication. But if their virus, of course, has become smart and mutated, and that one pill once a day isn't an option for them, and we have to get them to take it twice a day, that becomes a barrier. Taking that first pill in the morning, that's not so difficult. But remembering to take it, I'm a mom, I got to get my, the kids home from school, I got to feed them, I got to do the dishes, clean up, get everybody to bed, and I'm exhausted. Whoop, I'm sleeping in the chair, it's the next morning, and I forgot to take my pill. So these are definite barriers to that woman. May seem overwhelming on top of those caregiving and household duties. So it may not be just what they do within the home. It may be that there's extended family living in the home with them. It may be that they have a job or they have responsibilities outside of the home. These all can be barriers and challenges to a woman being successful with her antiretroviral therapy. Social relationships, juggling caregiving responsibilities with the adherence. If someone has not disclosed their status to their friends, their family, or their partner, now, I've got a big, huge bottle the size of a cup, and I got to hide that. Where can I hide that? It's often the bottle is bigger than that cup right there. And how do I hide that? So I bring that out and I open it up, and then I pull out a pill that maybe is the size of my thumbnail, and people are going, "What are you taking that for?" Ask a lot of questions. How are they prepared to answer those questions? Maybe they don't. One person asks the question, they go, oh, this isn't for me. Are they going to go back to their care provider and share those, those pieces of, they feel threatened, right? They feel that their diagnosis is going to be divulged. And if they don't have a good, trusting relationship with their care provider, they just get lost. They get lost to follow up. They stop taking the medication. It's just too much of a hassle to have to deal with that on a daily basis. So there's also some cultural beliefs as well. It depends on your population, especially sometimes in the immigrant population, and we definitely do have an immigrant population in Saskatchewan, persons that have been born outside of the country. Maybe in their country there wasn't even access to antiretrovirals. To them, being HIV positive is a death sentence. Then it is our responsibility to sit down and to talk to that client and help them understand that now they're in Canada. We do have medication. They can be successful with the medication, and it can help them to lead a long and productive life. I had one client who was given a prescription, and he'd been really faithful, coming to the clinic, never missed an appointment, was given that prescription, and away he went. So then all of a sudden, we didn't see him for a long time, and when we finally got him back re-engaged in care, was several months later. He was out of repeats, and he said, oh, well, I only thought I needed those 6. You gave me 6, 6 bottles, or enough for 6 bottles of medication, and I was done. I didn't think I needed any more. So, we'd missed the fact that he didn't comprehend that piece. So that particular time we got an interpreter on the phone, and we sat there with the interpreter and went through this again. And there was several different beliefs that he had, or things that he didn't really understand about how, we here in Saskatchewan would do our medication. And so ever since then, he's been quite successful. So it was just, our understanding. It's all a learning experience for both the client and the care provider. And these are pieces, I'm relating this to nurses because many times you are the one that stumbles across this little piece of information. I knew this patient hadn't been around for, I thought, where is he? Try to get someone to get him to come back into clinic. And then in talking to him, I stumbled across the fact that he thought he didn't need any more medication. So it's not always the pharmacist, but sometimes the nurse that, may have to do the counseling piece. Maybe the first person or the most common person, or the person that the client has that strong bond or strong relationship with. There may be violence or a fear of violence in a relationship as well. So, it may be that, the ability for the woman to get to the pharmacy isn't there. We know that sometimes in several different, in different cultures, the man is sits in a point of power. He has power over the women, so if he doesn't let her go to her clinic appointment, if he doesn't let her go and get her medication, that can raise a large challenge for the woman as well. Some of our women live on the street, or they may have had violence in the home and have had to go to a shelter. Do they want to bring out that pill bottle in an area where they live in common with others? Maybe not. Maybe they didn't even have a chance before they safely got out of their home to grab their medication. So these can all be many challenges and barriers to being successful with adherence. There's economic challenges. Although in Saskatchewan, this may or may not play a piece around the medication part, but we know that economic challenges have that inability to meet daily needs. We put our priorities. Medication may not be the top priority. The woman doesn't have enough money to get her to provide food security for her family. So these are things that she puts in a much higher spot than actually taking her medication. Because of course, as a woman, we often put our family, our children, and our partner in front of us. So having food security, having proper housing, having transportation, lack of adequate funds to pay for the medication. Sometimes they have to pay $2. Even having $2 is something that sometimes our clients don't have. And we've often, gone to our own purse and pulled out a toonie to give a client because we would not want to see a client go without their medication. And of course, as I mentioned, women put the children and the family's needs in front of their own. So potentially they're not getting to the pharmacy. They're not putting that, putting their own priorities first. And sometimes I think that's a little piece of education. We need to help them understand they need to stay healthy. They can't provide for their family if they don't stay healthy. If they aren't adherent and don't take their medication, then that's a little piece that is missing, that we need to sit down and talk quietly in that trusting relationship with the mom and help her understand how important it is that she keep on her medication and keep herself healthy to meet her family's needs. There's also gender roles and responsibilities. Some women need to ask permission, as I said before, from husbands or family members, lack of access to resources, and control of any resources. They may not, maybe they don't have any money because the partner, the male partner, controls all the funds, so when they go to the pharmacy and need that toonie or whatever little bit of money they need to get their medication, they don't have any funds. Next slide. There can also be rights of privacy and confidentiality, and I think as care providers, we can all tell a story about someone that has gone to a healthcare setting, whether it be a dentist's office, whether it is the emergency department, whether it's when they're admitted to hospital, where their privacy and confidentiality has been breached. Sometimes by well-meaning care providers that come into the room with, here's your HIV medication, and then took a look, and whoa, who else is in the room here? Maybe nobody else in the room. The mom, the mother-in-law, the sister, the cousin, maybe nobody else in the room realized that your client was actually HIV positive. Violations may include disclosing that HIV status in front of family members, other staff. There's always that HIPAA need to know piece. Maybe not everybody on the unit needs to know about the patient you are caring for and their challenges. Sometimes we have had situations, and we will see this in increasing numbers as both men and women are admitted to long-term care facilities where they are not prepared to accept clients who may have had previous addiction issues, who may be known to be HIV positive or known to be from the LGBTQ population. So human rights concerns during these hospital admissions or in preparation for this long-term care facility to accept one of our clients. We have recently had, one of my co-workers recently had a situation where a nurse put her hands on her hips and said, I didn't sign up for this, but I think we did. As a nurse, we signed up for whatever may cross our path every day. So poor communication within healthcare, limited time or effort from healthcare providers to address women's concerns and provide proper health teaching on the benefits and the complications of medication. Many women also report a lack of counseling. And so sometimes, remember, culturally, it may be that, when we're trying to counsel the woman, it may not be a female that's counseling them, but rather a male. And that may make some of our women feel very uncomfortable, and if they're uncomfortable, they're not going to hear everything, and they're not going to maybe vocalize those really important and concerning questions that they have. Is there some mental health issues and self-stigma? Are they feeling that they have a low self-image? There's some mental health issues and addictions issues that get in the way of them getting to their appointments. If they come to the clinic and they've just received their methadone and they're falling asleep, it's really difficult to provide adequate counseling. They really need to be rescheduled and get them to come back at a point in the day when they don't have that highest drowsiness rate or the most of the side effects from the methadone. A little bit later in the day after they've distanced themselves from their methadone dose for the day. That can all be helpful. Next slide. So women experience an increased risk of many side effects as well. So especially some of the older school medications can cause lipodystrophy, which is a shifting of fat. And if they've seen a friend of theirs have fat that has moved from the upper arm to their belly or even at worst to the back and caused a buffalo hump, they're going to go, this is not for me. Rash or hypersensitivity, nausea, vomiting, and diarrhea. If I feel really nauseated and, am I going to want to cook for my family? Maybe not. Weight gain, of course, we all worry about weight gain. So, I had a specific client who was very well attached to the clinic, and she got, she got a hold of her addictions issues. She was on methadone, and she started gaining weight. And she was taking antiretrovirals, and she looked absolutely fabulous. But she came to a point where she could not tolerate that weight gain anymore, and so she stopped. Without talking to us, she just went back into her addiction. We lost her to follow up, and it happened 2 or 3 times. And eventually we kind of overcame that barrier, but for her it was a huge barrier. She did not want to gain weight. It can cause an increased risk of metabolic disorders such as diabetes, emotional distress. Sometimes people have anxiety around taking that pill. We've had people look at the pill and go, I can't swallow that. And of course, not all these medications can be crushed and given in a different form. So, that again takes good counseling. And fatigue. How can we care for our family if we perceive that before we even start taking, we're going to be tired? Well, my friend, she was really tired all the time. She never got off the couch when she was taking her medication. So I don't want to get myself into that situation. I can't talk about medication without talking about the pharmacist, because the pharmacist does have a very, very important role. We as a nurse have an important role, but first line is that pharmacist. He and the physician, work together. So the pharmacist prevents medication errors. He works with the physician to select and review therapy and make sure that that the client is on the best therapy for them as an individual. We want to make sure that they talk to clients and counsel them very carefully around clarifying any medication changes or dosing changes, so that if something has changed, the client realizes that some of his medication may remain the same, but one is changed, or the fact that one is changed, we're not adding one, but we're changing one. We've all had similar situations where there's been a lack of communication. And these are all with goals to prevent development of resistance, as I spoke about earlier. The pharmacist's goal is to improve adherence and get our clients to as close to 100% as possible. In HIV land, we would say about 95% is our break point, and so that's missing 1 to 2 doses in a month. They want to manage drug interactions. So many of our clients are on other medications for their mental health, maybe medications for their diabetes. We want to make sure we look at all those medications. And as we have an aging population of women and men, we want to make sure that we're looking as they're adding high blood pressure medications, cholesterol medications. We want to make sure that there's no drug interactions. And also the pharmacist would want to monitor that response. 6 weeks and 3 months down the road, how is the viral load doing? Are we heading towards that non-detectable viral load? The pharmacist will also provide patient education, helping clients to understand and develop individual HIV therapy goals. He will educate the patients about possible drug interactions or adverse effects, explore solutions for those distressing side effects. So, he wants to send the client out to be successful. He wants to talk to that client about, okay, you may experience this, and if you do, try this. Or call me. Don't stop the medication because you get frustrated and you're not feeling well. Give me a call. Pick up the phone. It's all about good lines of communication. If you can't reach me, talk to the nurse. So it's all about keeping those lines of communication totally open. Help design interventions to enhance adherence as well. And so many of those are pairing the antiretrovirals with methadone. So there again, we're talking about good counseling. They're linked into care with not only the pharmacist and the team at the ID clinic, but they're linked into care with their methadone provider, and they can one-stop shop my antiretrovirals and my methadone, and it's all paired together for those that are accepting of that. There's other organizational tools, pillboxes, timers, alarms, and bubble packing. These are all things that can help with communication with the pharmacist. The pharmacy, helping patients to understand and develop individual HIV therapy goals. What is your goal? Where do we go? Where do you want to go? It's not ours to take. It's not the pharmacist to take. It's the client's to take, and we have to send the client out armed to be successful. So exploring solutions for distressing side effects, educating them about what to watch for if there is potential drug interactions, talking to them about, okay, if you've gone to your family doctor and he prescribed you some new medication, please pick up the phone and let me know that you're on some new medication just so I can double check and make sure that there isn't a drug interaction there. Next slide. So the nurse works along with the pharmacist as part of the team, and we've talked lots about team this morning, and this is a very good example. So we're working with the client to determine best treatment options for their lifestyle and needs. Sometimes the nurse in the clinic is the one that knows the client best, and so she can say, wow, I don't think that this is maybe the best option, and she'll give some reasoning for why she doesn't feel that a particular suggestion by pharmacist physician is the best option. Explain the importance of medication adherence. Pharmacist isn't always available. Sometimes you're picking up the phone talking about an appointment. It's just a prime opportunity to say, how are you doing with your medication? Exploring the client's values, beliefs, and attitudes about treatment. Providing information on potential side effects. Plan and enact strategies that will encourage and support their medication adherence. Educate the client on antiretroviral therapy using available and appropriate learning resources. So we all know our best learning resources for clients are found on Katie's website, so Canadian Canadian AIDS Treatment Information Exchange. Sorry, I stumbled over that. That can be found, if you just Google Katie, C-A-T-I-E, you'll be able to find that there's all kinds of great resources there, and it can lead you to some other resources as well. Nurses work with their clients to link them to primary care provider if that's the situation within your area, and understand the importance of routine follow-up. And sometimes, it's that nurse that hears the conversation as an appointment's being rescheduled, and you say, wait a minute, whoa, no, not 6 months down the line for this particular client. We just started him on new medication. We need to see him in 2 weeks. So it's the nurse that advocates on the part of the patient. So I just wanted to bring up one little scenario here. Colette is presented to the outpatient clinic for her appointment. She tells her nurse that her immune system is declining. Her doctor wants her to start taking HIV medication. She finds that she's terrified. And so here's that relationship she's developed with the nurse. She might not tell the doctor that she's terrified to start. She might not tell the pharmacist. She might just merrily take that prescription, put it in her pocket, and not do anything with it. So the nurse needs to act on these kind of comments and help the client to work through these, or bring these fears to the team's attention, so that together as a team you can develop a plan for this client. Next slide. So I just want to mention, and we talked earlier about the perinatal guidelines that Nicole talked about that were released in December of 2015, and what's the nurse's role within these guidelines. These guidelines can be found on the www.skhiv.ca site. They're easy to access there. If you're having trouble, it may need to be accessed using Chrome as your browser, okay? But they do have a variety of information sheets there. If you are in a health region other than the large 3 health regions, you need to make sure your health region is looking at these guidelines, that they've developed a committee to look at them, that they're ready to adopt them with that health region, so they're easily accessible and ready to use if a mom in labor happens upon your facility Saturday afternoon at 2 o'clock in the afternoon, when, or at 10 o'clock at night, when resources aren't as well available. And these do prompt you to call. It tells you how to get in contact with the professionals in Saskatoon and in Regina. It does talk about, AZT and how to, there's pre-printed orders there. So for health regions that may only do a few deliveries, they may not have that situation. So these pre-printed orders are all there. So there's a variety of information. The nurse also needs to know about that AZT that is talked about in these pre-printed orders. So as a nurse, if you're working in labor and birth area, familiarize yourself with zidovudine or AZT. You will be the one that's responsible to mix it up. You got a mom in labor and that drip needs to start. You need to be familiar about it, and you're going to put up that drug. She's going to say, what are you doing? You're going to need to know to be able to answer those mom's questions. So make yourself familiar with it. You may be the one that's discharging baby from hospital. So you need to talk to mom. In that package of resources, there is also a sheet that talks about questions related to administration of the med to the baby. It talks about the dose, when the baby needs to follow up, and little problems that might arise. What do I do if my baby spits that dose up? It answers all of those questions that a new mom might have, and it directs the new mom to the clinic numbers in Regina and in Saskatoon and in Prince Albert if mom is having trouble with baby taking these meds. Next slide. And I just want to show one little slide that talks about the HIV Continuum of Care, which is where we all base our team-related care. So number one step is all about getting a client. We need to get a client diagnosed. So it's actually getting someone tested. Recognize that they're at risk and trying to normalize the testing, getting everyone in Saskatchewan tested in the timeline that they need to be tested. So once we have a positive test, it's then getting them linked to care, making sure that they have an appointment with a specialist and that they have transportation. Remember our mom, she's got all kinds of kids, make sure that the appointment isn't at 8:30 in the morning when she's trying to get her children out the door. Make sure that she can get to the appointment and get home from the appointment, and it's at a time that suits her. Then once we've got her linked to care, the team engages her in care. And so it's our responsibility, as if we're working at the community, to make sure that she is getting to her appointments on an ongoing basis and staying engaged in care so that she can be successful with her medication. So that's step 4, getting that prescription, getting to the pharmacy, getting her pills, and step 5, taking them and being adherent to her medication and having that non-detectable viral load. So as a group, as a community, whether we're in hospital, in a clinic, in the community, whether we're a nurse, whether we're a doctor, whether we're a support worker, it's all our job to work together to get folks through step 1 and get them to step 5. Next slide. There's one more. Okay, so in conclusion, I just wanted to say, as we've talked about before, team-based approaches are important in HIV prevention, treatment, and care. Multidisciplinary teams are partnerships between workforce of health professionals, and it also includes our very important community-based organizations, and you hear from many of them this afternoon, that work towards that common goal, because it isn't just the pill or the doctor that prescribes the pill. It is all the other pieces around the pill, the community pharmacist, the person that drives them to the pharmacy to get their prescription, the person that checks on them. All of these people have to work together to make it successful. Team approach produces greater efficiency. So thanks everyone for listening, and if there's any, let's see if there's any questions here. Does anybody in the audience have a question related to anything they've heard from any of the three of us?
I do. Is it on?
Go ahead.
The question I have is, when it comes to the medication, now I know as an Indigenous person to this land, I'm not an immigrant, I have lactose intolerance. So every medication that I have cannot be a generic form of medication. It has to be the, what is that called, name brand, right? And so I get a letter from my doctor stating that I have to have name brand medication. Otherwise, I have side effects that are really can be perceived as something else. And I know that when it comes to Indian Affairs, they do not cover an awful lot of these name brand medications. They cover the generic form. So the other question is, do Indigenous Affairs, now it's called, cover all the medications for people who are HIV positive?
Yes, they do. And with the situation with antiretrovirals, right now there are very few generics. They're all name brand. There are very few generics right at this point in time. So it may be a concern as we head forward, but there is constantly drugs in development, and these drugs that come new on the market, is it 7 years? There's a period of time before they can use generics in place of those drugs on the market. So
I can comment about how, so the majority of the antiretroviral drugs are covered by NIHB, and they would be the trade name brands. Very few antiretroviral drugs have gone generic, like 3TC has, AZT, nevirapine has. But next year, some more drugs are going to go generic, like Truvada will be going generic in 2017, Atripla will be going generic. And we have to tick off, you can tick off no substitutes, and then NIHB sends you a form and you just have to fill it out. It's pretty straightforward getting antiretroviral drugs, and the majority are on NIHB, and there's no trouble.
Della?
Sorry, thanks, that was a great information about medication. I think what's really important is to appreciate how much work goes into starting people on medication, and that if it was just as easy as giving somebody a pill once a day, everybody would be on that. For those, I think, who work in getting them started, it's really important to assess the readiness. Some people might be really, really sick, but not ready to take those medications every day. And we really want to prevent any resistance. If that becomes a resistant virus and they're happen to be passing it on through the community, it would be a disaster. The other comment I want to make is about methadone in pregnancy. And oftentimes women who become pregnant and are on methadone have this idea that they should be reducing their methadone when they're pregnant. It might be bad for the baby, or they have this idea. Really, it's not, and they don't understand that as they gain weight, their needs for methadone are going to increase, because as they gain weight, they get less methadone per their weight. And so they need to be in contact with their methadone provider quite often, because often their needs for methadone do increase during pregnancy. So their methadone dose does go up, and we don't want them to start feeling any withdrawals. So that's the other comment. Comment about crystal meth. Oftentimes when people are using crystal meth, if they're just straight on crystal meth, we won't be starting them on methadone. We do a lot of preparation before we start anybody on. But when you're on crystal meth, a lot of times that's your up with their crystal meth or cocaine. And in combination, a lot of people end up getting started on morphine as they're down. So it's up, down cycle. So we do end up starting them on methadone if that's the case, and if they do have morphine in their
Perfect. Thanks, Della.
addiction.
I have one question behind the screen here. Mm-hmm.
Hi, I'm Kathy Johnson from AIDS Saskatoon. I have a question around payment for PrEP in Saskatchewan.
Yes, and that question was asked on remotely as well.
Yeah.
Okay, sure. So I bring up PrEP just to start the discussion. I think it's just something we haven't even started to discuss about, and I think there's opportunity there. First of all, Truvada, the Gilead has made the submission to Health Canada for the licensing of Truvada for PrEP, but that hasn't been made official yet in Canada. So technically, the province and the ministry in the province can't start discussing Truvada for PrEP until it's licensed for PrEP. So that's going to happen in 2016. So I think we can start. I think we should start the discussions. It should probably be monitored through like implementation, science programs. You know, how are we going to roll this out? I've seen PrEP programs rolled out in rural Cameroon. Like friends of mine have done that with success. So we can do it in Canada. But you know, I as a physician, I can prescribe a medication like off-label.
Yes.
They have to pay
Yes.
for it.
But right now they would have to pay for it.
Okay.
Yeah.
Yeah. Thank you.